Could you please introduce yourself?
Yeah, my name is Dr. Al Puerini. I'm a family physician practicing in Cranston, Rhode Island.
Can you briefly describe the concept of the patient-centered medical home?
That's a new concept, Drew, that really has grown out of the realization that our current way of approaching chronic diseases in patients isn't working, because we don't have the time, we don't have the facilities, and one person, the family doc, can't do it all. So what the concept is that we have a team of people. One of the key members of the team is a nurse case manager who pretty much looks at all the patients who have the diseases we want her to follow, such as diabetes, coronary artery disease, congestive heart failure, just to name a few. And then it's her responsibility to monitor, make sure those people come in for their visits, make sure that they're taking their medications, filling their prescriptions, and then from there, all other types of care that they need, physical therapy, psychological counseling, specialty care, will all be coordinated through our office, but through a team of specialists and ancillary healthcare professionals that is set up in advance. And so by setting up this entire team where everybody is either under the same roof or in the same neighborhood, say, someone could come in, and if, just for one quick example, a psychological issue or a psychological problem shows up, we can get the therapist right in, not so much for a therapy session, but to introduce herself and to start a relationship with her like that.
So it's clear there's a lot of advantages. What's going to be the cost in terms of added support and infrastructure?
Well, the cost, it's a double-edged sword, of course. If we want to achieve this, it is going to cost more money, but the reason why insurance companies and even governmental bodies are looking at this very seriously is that we think it's going to save a lot of money in the long run. If we can keep people healthier, make them more aware of their chronic medical disease, educate them more, then the logical result would be less hospitalization, less complications from their diseases, and a higher quality of life.
This has begun as a pilot program in Rhode Island?
It will. All right, we've been working on this. I happen to be one of the pilot practices. We've been working on it for over a year now, and the pilot is set to start July 1 of 2008. And it's a 2-year pilot. There's about 27 primary care physicians involved in the pilot. And if you multiply about average of about 2,000 patients per primary care physician, it's a considerable amount of patients. So we're pretty excited about it, and we're taking patients from all walks of life, socioeconomic status. We have health centers, we have private practices involved. So we're really looking forward to getting started.
If the pilot program is successful, when can we expect to see the changes?
Well, again, that's a tough question, because initially what we want to see is that doctors are achieving certain goals first, that they're getting their patients to keep their appointments, take their medications, go for the blood tests. 2 years is probably too soon to start seeing actual clinical results, especially and definitely too soon to see financial results. But I think at the end of 2 years we should be able to safely evaluate if this is working, if this initial phase of it is working, if people are more satisfied, if patient satisfaction is higher, if the physicians who are in the pilot will be getting paid a little extra to put this extra time in, and we'll see if they feel satisfied that the reimbursement is compatible with the amount of time that they're putting in.
Thank you.
Okay.